start, sir. Please start, sir.
Yeah. So, good evening, everyone, and good evening, respected doctors and our board speaker. It is a great pleasure to welcome all our respected audience and our board speakers to our today's eyesight meeting. So, first, let me introduce our board speaker. Our first speaker is Dr. Deepak Kumar Agarwal. Presently, he is working as a veterinary surgeon in the at Siliguri Greater Alliance Eye Hospital, Siliguri, West Bengal. He has more than 7 years of experience and has worked as an expert in different cities in India. He previously associated with Disha Eye Hospital, and Dr. Agarwal has contributed to handling numerous complex medical cases in several hospitals. He is known for his attention to accurate diagnosis and treating patients empathically. Dr. Deepak Kumar Agarwal did his MBBS from Kolkata Medical College, and he's also completed his MS from Kolkata Medical College in 2017. Our next speaker is Dr. Suklenmung Buragohai. Presently, he is working at Sri Sankaradeva Netralaya, Guwahati as a veterinary surgeon. So he has completed his MBBS from DRD Medical College, Gorakhpur, Uttar Pradesh in 2016. After that, he did his DNB in ophthalmology in 2021 from Sri Sankaradeva Netralaya, Guwahati, Assam. And he also did his fellowship from Sri Sankaradeva Netralaya, Guwahati, Assam in 2023. He has, Dr. Suklenmung Buragohai has more than 15 publications, and he has won lots of award and certificate from the various conferences. Recently, he has won Asia Pacific Association of Ophthalmology Achievement Award in 2026, and he has also won the IOC International Hero Award. So welcome Dr. Deepak Agarwal sir and Dr. Suklenmung sir for today's eyesight program.
Thank you.
And our first topic is translating research into practice, real-world application of DME management strategies. The speaker is Dr. Deepak Agarwal. So I'd like to welcome Dr. Deepak sir to present his presentation. Sir, please welcome and give your presentation, sir.
Thank you for that detailed description. So I think my slides must be visible now.
So I'd like to, Deepak sir, please switch on your, if possible, please switch on your video. So if possible.
Oh, sure. Yes, just a minute.
Thank you, sir.
Thank you. So today's topic for discussion is translating research into practice. Real-world applications of diabetic macular edema management and its strategies. So when we do a clinical trial, there are some limitations to this. The limitations being that in a clinical trial, there are strict criteria with regards to when the patient will be called upon, when the next injections will be given, and many more. Then there is a lack of consensus on the ideal treatment regimen for diabetic macular edema, and various approaches is being considered by different surgeons, doctors, like monthly injections or treat and extend protocol or Prorenata being used. This clinical trial data may not actually be very reflective of the real world scenario. So in diabetic macular edema, multiple anti-VEGF details has been done for ranibizumab, faricimab, brolucizumab. Multiple studies evaluating the effect of aflibercept has shown that aflibercept shows good clinical reviews in clinical trials. Now, why a real-world scenario is needed? Real-world data is needed because it measures the real-world effectiveness, which might not be very much apparent in the clinical data, in the clinical studies, which are very much conducted in a very specific format. Patient population in these real-world scenarios are unselected, diverse, and they are not pre-screened or selected on a defined criteria. Treatment is based on physicians' decisions, which might vary from place to place also. Typically includes diverse outcome measures. So this data provides us with real patient impact, worldwide differences, and has more value for the treatment of the real patients. Now, when the patients from VISTA study were further visualized and taken into follow-up for more 5 years, it was seen that mean of 3.4 injections were needed in year 5. Now, when the study was done on aflibercept, it shows that the real-world vision gains was very much consistent as seen in randomized controlled trials. Irrespective of the baseline vision, the aflibercept shows maintenance as well as visual gain with injections. Now, when we see from the baseline, there was mean VA from baseline to month 12. So there is poor baseline visual acuity in commonplace in up to two-thirds of the patients in clinical practice. When ranibizumab and aflibercept are compared, it is shown that aflibercept fares better compared to ranibizumab. The mean visual acuity gain from baseline till month 12 in patients who had poor visual acuity at starting was significantly higher for aflibercept when compared to ranibizumab. Now, a clinical scenario, we often see that we often substitute the dexamethasone implant in cases of DME. How does it fare up with aflibercept when compared with dexamethasone? So, a study was conducted between aflibercept and dexamethasone implant for diabetic macular edema in pseudophakic eyes over 1 year. And the results showed that both groups improved equally at 3 months. However, intravitreal aflibercept had 6.5, very much higher likelihood of more visual acuity gain of 3 lines. There is a chance of higher IOP in DEX implant at 6 months and 9 months. So now, what does the guidelines from India say with regards to laser and anti-VEGF injections? So anti-VEGF injection therapy is more effective in providing visual improvement in diabetic macular edemas. Therefore, it has been supplemented as the first-line therapy for diabetic macular edema. What are the international recommendations for visual acuity patients who are presenting with VCV of less than 69 letters, that is less than 20/40? Aflibercept is regarded as drug of choice in these patients. Aflibercept may lead to a more rapid visual improvement when compared to ranibizumab, and aflibercept has been found to be superior in the group participants with worse baseline visual acuity. So multiple research is showing that aflibercept is more favorable when patient presents with lower visual acuity, that is less than 69 letters or less than 6/12 or 20/40. Now, as we know that meta-analysis are more valuable in terms of research data analysis. So a Cochrane meta-analysis was done to review the efficacy of anti-VEGF agents in DME. It was found that at year 1, when all the anti-VEGFs were compared, aflibercept was showed more favorable outcomes compared to ranibizumab and bevacizumab. Patients were 30% more likely to gain more than 3 lines with aflibercept rather than other anti-VEGF agents. Now, meta-analysis are very much important in making our decisions. So what other meta-analysis are suggesting? So VCV changes were found to be more with aflibercept than ranibizumab. Again, we see that mean BCVA change as well as mean change in central macular thickness showed favorable outcome for aflibercept when compared to ranibizumab and other dexamethasone implants as well. So aflibercept is most favorable treatment in terms of BCVA improvement and central macular thickness with compared to other therapies for management of diabetic macular edema. Multiple international guidelines recommend aflibercept for the drug of choice in patients with phase-corrected visual acuity of less than 69 letters. Let's look at the scenario throughout the world. The EURETINA guideline says that aflibercept is the drug of choice for visual acuity less than 20/40 at presentation. Asian recommendation says that aflibercept may result in a more rapid visual acuity improvement rather than ranibizumab. Diabetes Canada guidelines again show superiority of aflibercept when compared to other groups. This table is very important. It shows the value of different types of study. So what we see is that when comparing different types of study, systemic reviews or meta-analysis are regarded as the best level of evidence or the highest level of evidence. So when meta-analysis is done and they are showing that aflibercept is more favorable compared to other drugs. Now, aflibercept is recognized as the standard of care for DME and is being used in DRCR retina network protocols, evaluating anti-VEGF injections for DME and diabetic retinopathy. Thank you.
Thank you, Dr. Deepak Agarwal, sir, for your wonderful presentation. So
Thank
if there is a question, the audience can ask to Dr. Deepak Agarwal, so he will reply all the questions. If there is no questions, then we will go to the next topic. The next topic is the evolving role of aflibercept in PCV, APVRS insight and comparison with anti-VEGF agent. The speaker is Dr. Suplen Murmu Boragohai. So I would like to request Dr. Suplen Murmu, sir, please present your presentation.
Thank you. Are my slides visible?
Sir, your slide is visible. So.
Okay. So at the outset, I would like to thank Bayer Group for this opportunity for me to present. So my topic is the evolving role of aflibercept in PCV and APVRS insights and comparisons with anti-VEGF agents.
Sir, I'd like to request you, please, if possible, please do the full screen, sir.
Is it not full screen?
No, I think. Hello, tech team. Yes.
Yes, sir.
The full screens. I think these full screens are not showing. No, is it full screen or?
Yes, sir. Make a full screen.
Okay. Thank you then, sir. Please continue, sir.
Okay. So these are my disclaimers. So currently the guidelines for PCV diagnosis involves the use of OCT, ICGA, FFA, and even OCTA. So according to the APVRS guidelines, right now, the modalities such as OCT can be used for diagnosis of PCV alone, with major criteria such as sub-RP ring-like lesions and fast OCT complex RP elevations and sharp peaked PD. However, the gold standard for diagnosis of PCV still remains ICGA. So the initial treatment which is available at present for the treatment of PCV involves anti-VEGF monotherapy or a combination therapy with anti-VEGF and photodynamic treatment. So after treatment with either anti-VEGF monotherapy or anti-VEGF and PDT, we have to monitor the response with OCT or ICGA. If there is complete regression or there is stabilized SRF, the treatment regimen changes to treat and extend. Or if there is persistent activity of the disease, then the treatment can be shortened with treat and extend regimen, or it can be switched to combination treatment with anti-VEGF and PDT, or it can be switched to another anti-VEGF agent. However, if there are other conditions such as the presence of very large submacular hemorrhage, then we can also use pneumatic displacement with or without vitrectomy and with or without TPA. If there are active extrafoveal polypoidal lesions, then we can also use thermal laser ablation in adjunct to anti-VEGF therapy. So according to the APVRS guidelines, monotherapy with anti-VEGF treatment is effective in many cases of PCV and can be used initially as monotherapy. And to date, there are no, data exploring whether faricimab or brolucizumab monotherapy are non-inferior to combination therapy in patients with PCV. So in this slide, there is a comparison between the different types of anti-VEGF agents which are available for use. So all of them differ in their molecular structures and their VEGF affinity, their durability, and the spectrum of action. Ranibizumab primarily targets VEGF-A, whereas aflibercept additionally inhibits VEGF-B and placental growth factor. And it results in a stronger fluid resolution and PED control in PCV. Newer agents such as brolucizumab and faricimab aim to improve anatomical outcomes and extend treatment durability. In PCV, treatment success depends not only on visual gain, but also on polyp activity, hemorrhage prevention, and reduction of treatment burden. So in 2006, a pivotal trial was done, which was the Everest-2 study, and it demonstrated that ranibizumab monotherapy led to more treatments with inferior vision gains in comparison with combination therapy with photodynamic treatment. In VIEW 2 study in the same year, it demonstrated that patients with PCV and patients with neovascular AMD can achieve similar vision gains with aflibercept 2 mg monotherapy in comparison to combination therapy. So in this, you can see that the patients with PCV and patients with neovascular AMD achieved similar vision gains with aflibercept monotherapy. In the PLANET study, it has demonstrated that aflibercept monotherapy was as efficacious as combination therapy over 2 years in patients with PCV. So PLANET was a prospective sham control study which assessed the efficacy of aflibercept monotherapy compared with aflibercept with PDT for the treatment of patients with PCV. So aflibercept monotherapy achieved clinically meaningful visual outcomes in patients with subtypes of neovascular AMD such as PCV. So here you can see the mean change in BCVA from baseline through week 96 in the PLANET study with aflibercept monotherapy and with the optional treat and extend dosing in year 2. So the PLANET study highlights one of the major advantages of aflibercept in PCV, that is durability with maintained vision gains. In year 2, many patients were successfully extended to 10 and even 12-week treatment intervals while still maintaining approximately 10 to 12 letter visual improvement from baseline. Importantly, the number of injections remained low despite sustained visual outcomes, demonstrating reduced treatment burden. Another key observation is that aflibercept monotherapy performed comparable to aflibercept with rescue PDT, further supporting the whole PVRS concept. Many PCV patients can be effectively managed with aflibercept first, treat and extend strategies, reserving PDT for selected refractory cases. So in Altair study assessed the efficacy of aflibercept treat and extend at 2 or 4 week treatment intervals adjustments in patients with and without PCV, which were approximately 37% of the patients. So the treat and extend adjustment criteria was to shorten which was shortened to a minimum of 8 weeks with new or persistent fluid, with unchanged or increased fluid volume with measurement at the previous treatment, which was indicated on OCT, or the loss of greater than or equal to 5 ETDRS letters from the previous visit, or an increase in central retinal thickness of greater than or equal to 100 microns compared with the previous value. So in another study, Maruko et al., the same treat and extend regimen was used for patients with PCV and typical neovascular AMD. In these, 97 eyes were enrolled in the study. Eyes received a loading phase of three loading doses of monthly aflibercept 2 mg, followed by treat and extend. So in these, you can see that the mean number of injections in the PCV subgroup was 12 versus 14 in the typical neovascular AMD group, which showed that there was a reduced treatment burden with the use of aflibercept monotherapy. There were other studies, and the study by Hosokawa and colleagues demonstrated approximately 8-letter visual improvement at year 1, while the Morizane and Hosokawa data showed sustained visual gains of around 9 letters at year 2. These benefits were achieved alongside extended treatment intervals, which emphasized the durability. A key observation here is that nearly 60% of the patients achieved 12-week intervals by year 1, and close to half reached 16-week intervals by year 2. This reflects one of the major advantages of aflibercept in PCV, that is the ability to maintain anatomical and functional stability while reducing injection burden. In this slide, you can see that the complete polyp regression has been observed across various real-world case series with aflibercept in PCV. Here, the variability in polyp regression rates are much likely due to the differences in polyp regression assessment criteria across the different study groups. So, in comparison to another study which used faricimab for treatment of PCV, you can see the differences between the two. So both the primary endpoint in the PLANET group was non-inferiority of aflibercept monotherapy versus aflibercept and rescue PDT for BCVA change from baseline to week 52. While in the Salween study, the mean change in BCVA from baseline, it was the mean change in BCVA from baseline and averaged over weeks 40 to 48. So in these two studies, we can see that the number of visual acuity gain in the PCV in the aflibercept group was much more and statistically significant at 3 months after the first treatment. But this was not observed in the faricimab group. Also, the eyes with fluid, the number of eyes which achieved more fluid resolution was aflibercept in comparison to faricimab. Also, the percentage of eyes which got complete polypoidal lesion resolution was seen to be more in the aflibercept group. In conclusion, this study showed that both intravitreal aflibercept and intravitreal faricimab are effective in reducing exudation and retinal thickness. However, intravitreal aflibercept was more likely to eliminate exudative changes and improve visual acuity after 3 loading doses. There are notable unusual findings from this trial to other RCT studies conducted, which the authors discussed, and we will explore it further later. However, I would like to share a few clinical cases of PCV. So the first case is of a 60-year-old male who had a presenting vision of 612 parts and N10. So in the fundus, there was over the fovea, there was some submacular hemorrhage with FFA showing a polypoidal lesion, and OCT of the corresponding section showed a tall PD with subretinal hyperreflective material and subretinal fluid, as well as few areas of intraretinal fluid. So in this, monotherapy of aflibercept was used, and in the first post-op, after 1 loading dose, we could see that there was a lot of resolution of the submacular hemorrhage. Also, the subsequent OCTA showed significant resolution of subretinal fluid, along with decrease in the PED height. This is a very short case, and the patient still has taken his 2nd loading dose and still has to come for a follow-up for this 3rd loading dose. The second case involves a 50-year-old female who also presented with a submacular hemorrhage, which was very large in comparison to the last case. And also on the OCT, you could see very tall PDs with subretinal hyperreflective material. And in this case, also we used intravitreal aflibercept, and the patient underwent 6 loading doses of aflibercept at a monthly interval. So this was the first fundus image after the first loading dose, in which we can see that in comparison to the previous image, a lot of the subretinal hemorrhage had reduced. This was after the 3rd loading dose, the 4th, the 5th, and this was the 6th. So the OCT after the first loading dose was these two. The first one is the horizontal one, which you can see that a lot of SRF has reduced and the submacular hemorrhage has reduced over the fovea. And in the second one, the below image, we can see in the vertical section the polyp height, which has also reduced along with the subretinal hemorrhage. And these are the subsequent OCT images of the same fundus images following the 6 loading doses. This is after the 2nd loading dose, this after the 3rd, the 4th, the 5th. So in conclusion, aflibercept has established a strong evidence-based in PCV through both RCT and extensive real-world experience. Its major strengths include effective fluid control, PED reduction, visual stabilization, and improved durability with treat and extend regimens. The long-term safety profile has also remained reassuring, with low rates of intraocular inflammation and endophthalmitis. From an APVRS perspective, the management paradigm in PCV has evolved significantly over the past decade. Current insights emphasize that PCV is a distinct pegchoroid-driven disease, and treatment goals should focus not only on polyp closure, but also on maintaining a dry macula, preventing hemorrhage, reducing treatment burden, and preserving long-term vision. Aflibercept has played a central role in this shift, allowing many patients to be managed effectively with monotherapy and selective use of PDT. Thank you.
Thank you. Thank you, Dr. Suklaman, sir, for your wonderful presentation. So now floor is open. So if anyone have any questions, so you can ask Dr. Suklaman and Dr. Deepak Agarwal, sir. Hello, Saurabh. Hello. If there is no question, so we can close to our student session. Hello.
Hello.
That team.
Yes.
Hello, sir.
So as there is no questions, I think we can wrap up it.
Yes, sir. Yes, sir.
Okay. Thanks a lot for the opportunity.
Yes, sir.
Okay. Signing
Thank
out.
you once again, Dr. Deepak, sir, and Dr. Suklan, sir, for your presentation.
Thank you.
Thank you. Thank
And
you.
good night.
Yes. Good night. Yes. Good night.